When a major coronary artery suddenly blocks and the heart muscle seizes, the body enters a strict biological countdown. Blood flow stops, and cardiac tissue begins dying by the minute. The logistical path for a patient follows a specific sequence. From the initial symptom onset, they wait for medical contact, are transported to the hospital, and finally reach the surgical table for PCI to physically open the blocked artery. This graph reveals the biological bottleneck. The slow orange line tracking downstream oral loading shows that standard pills given to stop blood clots take 4 to 6 hours to reach full strength in the bloodstream. This delay occurs because the gut effectively shuts down during a severe heart attack. The body diverts blood away from the stomach, and common pain medications like morphine further slow gastric absorption. The medication simply isn't absorbed in time. This physical absorption delay creates a vulnerability window. While the patient is rushing to the hospital, their bloodstream remains largely unprotected from the exact clots that are causing the cardiac event. Cardiologists face a conflict between two competing needs. They must administer antiplatelet drugs early to provide protection against clots, but doing so too early introduces the risk of the patient bleeding during emergency surgery. This forced balancing act often happens before doctors have a clear picture of the patient's internal anatomy. They have to weigh the immediate need for protection against the possibility of surgical bleeding. The risk is highest if a patient ends up needing a CABG, an open heart bypass. The CABG impact means pre-treated patients face longer waiting periods for the drugs to wear off, or significantly higher bleeding risks if surgeons must operate immediately. Without immediate data on the patient's condition, standard oral pretreatment requires a difficult choice. Clinicians must weigh the immediate threat of a clot against the potential for surgical complications the following day. For non-ST elevation myocardial infarction, or NSTE-ACS, where the artery is only partially blocked, the medical consensus has shifted towards waiting for more information. For NSTE-ACS, the 2023 guidelines issue a Class 3 recommendation against routine pretreatment. The ACOAST trial showed prasugrel doubled major bleeding without benefit, while ISAR REACT 5 found deferral superior. Furthermore, the SWEDE Heart Registry of 65,000 patients confirmed early pretreatment only increased in-hospital bleeding. For NSTE-ACS, the evidence suggests that early oral loading causes measurable harm. This has led to the current protocol of deferring treatment until the patient's anatomy is known. The protocol changes for a STEMI, a total blockage of the artery. This presents a higher risk for recurrent ischemia, leading to complex clinical guidelines. The data in these cases is varied. The Atlantic trial tested pre-hospital ticagrelor and successfully reduced stent thrombosis at 30 days. In contrast, the PCI Clarity trial demonstrated that clopidogrel pretreatment led to a 45% reduction in cardiovascular death or stroke. Even in stable coronary artery disease cases, trials like PROG-8 show that pretreatment consistently increases the risk of minor bleeding. In severe STEMI cases, the need to prevent lethal clots often leaves doctors with no choice but to use oral drugs, despite their slow and unpredictable absorption. To address the biological bottleneck, treatments must bypass the stomach entirely. This provides instant protection without the long-term surgical bleeding risks associated with oral pills. This chart outlines next-generation injectable therapies. The top red row shows intravenous Cangrelor acts in under 2 minutes, with a short half-life of 3 to 6 minutes. The clinical pearls column notes it serves as a reliable bridging therapy for intubated or shock patients. The efficacy of this approach was demonstrated in the Champion Phoenix trial. Among 10,000 patients, this intravenous strategy reduced major adverse cardiovascular events by 20%. Cangrelor demonstrates that rapid, highly reversible drugs can provide immediate protection while allowing for the swift withdrawal needed if a patient requires emergency surgery. Shifting to the pre-hospital environment is the next focus. Subcutaneous autoinjectors are developed for paramedic use or patient self-administration at the first sign of symptoms. The middle orange row shows selatogrel. This subcutaneous inhibitor achieves a 91% response rate within 30 minutes. Below that is zalinfaban, which uses a low-toxicity mechanism displacing magnesium ions to prevent clot-forming proteins from binding, avoiding permanent receptor alteration. Early results from the CELEBRATE trial indicate that giving zalinfaban before reaching the hospital improves early reperfusion in STEMI patients without increasing major bleeding. By shifting from slow, delayed oral pills to rapid, reversible injections, clinicians are shrinking the vulnerability window. This transition is providing patients with the protection they need during the most dangerous minutes of a heart attack.